Hello, my name is Debbie Teodorescu. I'm an attending physician at Mass General Hospital, and I'm here to talk with you about admitting the patient with COVID-19 to the ward. For relevant disclosures, all content is for informational and educational purposes only, and all opinions expressed are mine, based on my experiences. So the very common patient that my colleagues and I in the hospitalist service are taking care of during the surge is a 30-year-old gentleman who is Spanish-speaking with no known past medical history who presents with 5 days of progressive non-productive cough and dyspnea. There are often very many iterations of this, of course. There are also the folks who have more comorbidities or who might have a touch of obesity or hypertension or things of that sort. But generally, we're seeing on average a much healthier cohort of patients who come in with COVID-19. And that challenges our decision making. Usually our eyeballs are very accurate at looking, trained with the curve 65 admissions and things of that sort. People who are otherwise healthy and have very little wrong with them and are young can look very different when they're incredibly sick. And so it has been very helpful for us to look systematically at how the patient's been, especially not only querying the vital signs, but also looking at the ambulatory pulse oximetry and recognizing that symptom burden. Even the absence of hypoxemia can be pretty significant. Patients can absolutely run into problems with just plain work of breathing. Expected potential illness course. COVID-19 is a dastardly disease. We've seen it get better, get worse. We've seen it get worse after 4 weeks or longer. But we generally have found that the scariest time in many ways is really the first 2 weeks of illness. And then, of course, we add in any comorbidities. Then, as Fred was telling you about in a separate presentation, there's the risk calculations that go into it. And at the end of the day, we have to recognize that in patients who often are multi-generational homes or have very challenging jobs or have very limited medical follow-up, we have different risks about follow-up in community than the average. We also have to recognize, of course, that in the midst of even the worst of surges, not all respiratory symptoms are COVID-19. We have seen plenty of patients who ultimately have been found to have heart failure exacerbations or just plain COPD exacerbations. And of course, we've also get more exotic things, such as the patients who present with first severe vasculitis. I've had a patient who had first ever PJP presentation with new onset HIV. So all sorts of things can still be true. So keeping your antenna up is still critical. So there's a decision of, are they coming to the floor or are they going home? And there's also the decision of, are they going to the floor or are they going to need a higher level of care? So reality checking is always critical. Critical pass-off information, there's the usual things of age, the comorbidities, your diagnostics and interventions, but another key thing is the day of illness, as we're talking about O2 requirement or work of breathing to convey just how worried you are about a patient, as well as any information and communications and goals of care. One thing I really appreciated that RED did was to really buff up the social work, case management, and palliative care services availability down in the ED, because that has really helped to get some critical communications going that sometimes help patients get out of the hospital or at least help to inform their hospital course up front. So communicating those as patients go from provider to provider is absolutely key. I won't belabor the details of PPE too much. As one of the PPE buddies at Mass General, I would say that it's been actually quite useful to have to mutually train one another, nurses, physicians, respiratory therapists, physical therapists. Everybody's got skin in the game, and to help each other out to be one of those spotters, especially because if supply chains get stretched, sometimes we wind up using masks and shields that are different from usual. And so extra training can be helpful in that regard, or at least mutual support. Most of the equipment is familiar for anyone who's taking care of anyone with respiratory illnesses or MRSA or C. diff. But I would really emphasize the extent to which during the pandemic, it's good practice to try to minimize the amount of staff in the room and frequency of room checks. So anytime you're able to use continuous monitoring instead of spot monitoring, using telemonitoring, using phone for the patients to ask you a quick question or you to ask the patient a quick question, anything like that is really helpful. Our pharmacy staff are amazing about helping to deliver spacers so that we could provide inhaled treatments without using nebulizers. And then, of course, having a patient wearing a surgical mask, at least during transport, but sometimes even in the room, is incredibly helpful from a safety perspective as well. Ideally, every patient should be in a negative pressure private room. We know, of course, how challenging that is. So the reality is anytime you have more privacy, more space between patients, more barriers between a patient and someone else, that's awesome. Please stay safe whenever you're in any sort of extended exposure space. You have to recognize that there are implications for bedside testing and treatment modalities. So anything from lab testing to portable x-rays or ultrasounds, things of that sort. We are very fortunate to have the radiologists, the technicians, the phlebotomists, and other members of the extended care team who are affected be very active members of a discussion up front to establish policies to ensure that patients are getting care, but that their staff are still staying safe. There is extremely active work ongoing in the field of what is safe and what is not for oxygen delivery. So I'm going to go for the extremes of things we know are definitely safe and definitely are not. We know for sure that low-flow nasal cannula as well as non-rebreather masks are as safe as taking care of a patient who's coughing or who's talking with you without wearing anything else. We know from the SARS epidemic that there is an extremely high risk for patient providers who are not wearing PPE to contract potentially fatal infection from intubation and CPR if they're not properly protected. There have been a lot of solutions, such as MGH, for example, opted to develop a homegrown solution to contain aerosols during intubation to provide a passive barrier. It's called the Apollo Hood, is now commercially available. But like I said, very, very active area investigation. There's a lot of frequently asked questions from the patients as well, especially as recognizing that these are often healthy patients with limited medical engagement. So I heard that there's no treatment for this virus, so how can you help me? Fortunately, we do have some treatment modalities, as my colleague Ben will be telling you about, but there's also just plain pointing out that you're providing oxygen, you're providing supportive care, you're helping to provide a place for them to isolate from their families is also important. Am I going to die comes up incredibly often because of the fear that the pandemic has created for so many members of the community. What can I do to get better faster? It's so scary when someone's healthy usually. Now, without the power to feel better. And that's where things like pruning, I feel like, have a tremendous benefit, ensuring that they feel like they're an active part of their recovery process. It's incredibly traumatic when family and friends are not able to be part of the healing experience. And so engaging in infection control and figuring out the policies, as well as figuring out how do you virtually engage. I often will have patients' family members on the first video call during admission because that's helpful for them. I think it's incredibly critical that we have any translators actively engaged as well so that patients feel very comfortable in talking through the illness. And then, as we always have to talk about goals of care, code status on admission, why are you asking me about these things? Are you thinking I'm going to need them? Are you thinking that you would ration them? Things of that sort. So this is an opportunity for us to build our therapeutic alliance, not only with the patients, but also with the greater community, to ensure that they know that we've got their backs, we care about their well-being, we just want to make sure that they're getting all the care that they want and that makes sense for them. Thank you very much, and stay safe out there.